Okay, so we're going to go over liver enzymes and the liver. And what is the liver? The liver is the largest gland in the body. It weighs about 1.4 kilograms, which is 3 pounds. It's shaped like a wedge. It's on the right side of the patient's body, and it extends further to the right body to the midline. It's located under the diaphragm. It lies almost entirely under the rib cage where it gets really good protection there. It has four primary lobes. It has a hepatic artery and a hepatic portal vein. The hepatic portal vein is the vein that drains um, all the venous return from the esophagus, the gut, the intestines. Okay, so that's the hepatic portal vein. What does the liver do? It's important for cholesterol metabolism, fat metabolism, protein metabolism, vitamin and mineral storage. Remember, it stores vitamin A, D, E, and K. I always remember A, DEC, and vitamin K, not potassium. Okay. And also biotransformation. So biotransformation of medications, biotransformation of nutrients. Cholesterol metabolism, it converts galactose and fructose to glucose. It stores glucose as glycogen, and it performs glycogenolysis and releases glucose into the bloodstream. Gluconeogenesis, so you remember genolysis means something's being broken down. So we are taking a stored glucose such as glycogen and lysing it to release the glucose into the bloodstream when it's needed. Gluconeogenesis is going to convert amino acids and glycerol to glucose when glycogen stores are exhausted. And then also during starvation when blood glucose levels are failing or falling. It also converts glucose to fats that we can store. That would be, like storing it as a triglyceride. Um, Fat metabolism, it breaks down the fatty acids to acetyl-CoA. It converts excessive acetyl-CoA to ketone bodies for release to tissue cells, and it also stores fat. So it forms lipoproteins for transport of fatty acids, fats, and cholesterol to and from tissues. It synthesizes cholesterol from acetyl-CoA and catabolizes cholesterol to bile salts, which are secreted, therefore, into the bile. So remember, the liver makes the bile, but the gallbladder stores it. Protein metabolism. So it deaminates, which means it's the removal of an amine group. Amino acids, amount of deamination that occurs outside the liver is a little unimportant, but it forms urea for removal of ammonia from the body. Inability to perform this function, such as with cirrhosis or hepatitis, that can result in accumulation of ammonia in blood. If we get an accumulation of ammonia in blood, it is toxic to the brain and it can develop into an encephalopathy. What we typically see with patients with hepatic encephalopathy, they get like a flapping bird tremor, like this. And we call that asterixis. Okay. It does form most plasma proteins, and transamination is going to be the intraconversion of non-essential amino acids. The amount that occurs outside the liver is really inconsequential again. So vitamin and mineral storage, we do know that it stores A. It does store some B12, about 1 to 4 months supply of D and B12. But remember, A, D, vitamin E, and vitamin K. It stores sizable amounts of vitamin D and B12. We have a 4 month supply there. Okay. Stores iron. Other than iron bound to hemoglobin, most of the body's supply is stored in the liver. So you do have iron that is bound to your hemoglobin, but then when that breaks off its stores, we recycle it. So when the red cells go to the spleen, that's what I call the graveyard. It will actually break up the red cell in the fragments, and it will take that iron and bind the iron as a almost like bilirubin, okay? So it's a non-conjugated. It will bring that iron back to the liver, and then the liver will store that iron. It doesn't take the ones that are bound to the hemoglobin, but most of the body's supply of iron is stored in the liver. We store it as ferritin until it's needed, and then when we need it, we can release that iron into the blood as the levels start to drop. Relative to alcohol and drug metabolism, this is about biotransformation functions. It performs synthetic reactions which yield inactive products that can be secreted by the kidneys, and then non-synthetic reactions which may result in products that are more active, changed in activity, or less active. Processed bilirubin resulting like what I was just talking about from RBC breakdown, and it will excrete the bile pigments into the bile. So that's where the bilirubin ends up, is it gets broken down and used for bile. It also metabolizes blood-borne hormones to forms that can be easily excreted in the urine. Here's ascites. So this is your liver. So when we see patients that have liver dysfunction such as cirrhosis or hepatitis, if they can't make the proteins such as albumin, then what happens? The fluid component in the bloodstream wants that albumin there so it can, remember, always goes to a concentration where it can make it balanced. So if we don't have enough albumin in the bloodstream, then that fluid will shift, and the fluid can shift into the abdomen, and we call that ascites. It makes them look like they have a really big abdomen, okay? But it's all fluid. And in order to get that fluid off, they can do an ultrasound guided paracentesis and take that fluid off. This is what it looks like, and you'll see it's highly vascular, but this is not fat. This is all fluid, and we can tell because you can do an ultrasound and see that free fluid. So in cirrhosis, here's our cirrhotic. Our cirrhotic liver, as you can see, has a lot of scar tissue, nodules, where the normal liver is fairly smooth. Now, how do we know when there's damage? Sometimes we can detect that through liver enzymes. Remember, if the cells are still producing enzymes, we're going to see elevations in those enzymes. As the hepatic cells die off, they turn into scars. They will not produce enzymes anymore. So sometimes in really advanced levels of hepatitis and cirrhosis, you may look at the labs and say, why aren't they really elevated? Well, the hepatocytes are basically turning into nodules and scars, and they're not producing them anymore. But usually what we're going to see in normal adults is the alanine aminotransferase, also known as the ALT. They used to use an old term called SGPT, for the adult, 10 to 35 units per liter. And men maybe, levels could be a little higher. In children, an infant could be twice as high an adult. Okay. And a child is similar to an adult. In the elderly, you will see slightly higher levels in an older adult, in the elderly, of the ALT. I always think if the ALT's higher than the AST, then I think there's a liver primary problem. Okay. When we look at the effectiveness in diagnosing hepatocellular destruction, it is found in small amounts in the heart, the kidney, and skeletal muscle, and serum levels can reach up to 200 to 4,000 units per liter. ALT is used to differentiate between jaundice and hemolytic jaundice. And what is hemolytic jaundice? That means you're having true hepatic jaundice, means the liver is the problem if the ALT is elevated. Sometimes in hemolytic, which means hemo, blood, lysis, when we have, like, called a hemolytic anemia. Sometimes malaria does this. This is one of the reasons malaria is called black water disease. It will lyse the red cells, and then what happens is all the the iron and all the the waste products of the red cell as it separates, the bilirubin is unconjugated. So they'll actually have early destruction of their cells. Sometimes we do see hemolytic anemias as a problem with drugs, certain medications, psych meds, certain drugs. So they'll use the ALT to kind of differentiate, is it the liver that's the problem? Do we have cirrhosis? Do we have hepatitis? Or do we actually have something happening with our red cells, and that's why we're turning yellow? Serum ALT levels will rise typically before the jaundice appears. So ALT compared to AST for diagnostic purposes, ALT is more increased than AST when it's liver necrosis or acute hepatitis. AST is more increased in myocardial necrosis. So sometimes you'll see ASTs elevated with heart, cardiac issues, MI, cirrhosis, cancer of the liver, chronic hepatitis, or liver congestion. But its purpose is to determine a liver disorder. So what are some of the clinical problems? If you exercise or you take salicylates like aspirin, you'll have decreased levels. Increased levels, you'll see high incidence if it's acute viral hepatitis, okay? Like your hepatitis A, your hepatitis B, your hepatitis C, or if you have necrosis of the liver, such as like with cirrhosis. You can have slight or moderate increases with cirrhosis, cancer of the liver, heart failure. Yes, heart failure can, especially if it's left to right-sided of heart failure and you get this hepatomegaly, and also acute alcohol intoxication. Drug influences, antibiotics, narcotics, antihypertensives, and even heparin can cause elevations. So, what do we do when we draw them? We don't usually need to do any kind of fluid restrictions. We will collect that blood about 3 to 5 milliliters in a red top tube. We always want to avoid hemolysis. That means the breakdown of the cells that'll release potassium. Any drug that can cause false positives will be listed. So like if we can always list what the patients take, what medications they take on the lab slip. And then that way the lab will know that that could have been the problem, such as what we see with aspirin, and certain other drugs can actually increase the ALT. And if we have hemolysis happening, like the breakdown of cells, red cells specifically. AST. So this is called aspartate aminotransferase, or serum glutamic oxalate transaminase, which they used to refer it to as SGOT. Average in adult range is going to be between 8 to 35 units a liter, and females may be slightly lower in this category. Newborns up to 4 times the normal. So just remember, newborns tend to be very high in liver enzymes, and the child is similar to adults. In the elderly, you might see it slightly higher than in adults. So AST or SGOT is found mainly in heart muscle, liver, moderate amounts in the skeletal muscle, kidneys, and the pancreas. The concentration is low in the blood, except when there is cellular injury, and then large amounts are released into the circulation. High levels are found after an acute MI, not but after an acute MI. 6 to 10 hours after an acute MI, AST will leak out of the heart muscle and it will reach its peak in about 24 to 48 hours after infarction. So we do look at these liver enzymes if we're ruling out MIs. AST levels tend to return to normal 4 to 6 days later if there's no additional infarction happening. Serum AST is usually tested along with other cardiac enzymes like your CK, your LDH, and of course our troponins. In liver disease, it can increase by 10 times and it will remain elevated longer. But we look and we frequently compare AST and ALT. We do use the AST to detect elevation after heart and liver damage. And then you compare the AST with CK, troponins, and LDH if we're diagnosing an acute MI. Decreased levels, we can see pregnancy, DKA, chronic hemodialysis, drug influences, salicylates can definitely decrease these levels of AST. In increased levels, we will see increased levels with alcohol intoxication, acute MI, hepatitis, liver necrosis, musculoskeletal disorders, trauma, acute pancreatitis, cancers of the liver, angina, strenuous exercise, and even giving an IM injection because it's found in intramuscular injections or in the muscle. And we do find AST in the muscles. Drug influence, antibiotics, vitamins, narcotics, and antihypertensives. And as I mentioned, alcohol can influence your ASTs. For this, again, no food or fluid restrictions. We collect about 3 to 5 milliliters of venous blood in the red top tube. We draw blood before drugs are given. And then what we'll do, so we'll tell them to hold, like I say, just hold that med, and then after we draw the blood, then you can take it. And also, we always want to make sure on the lab slip we write the meds that can cause the false positive. I just write all the patient's meds because I never know. Liver enzymes, AST factors affecting results. IM injections when we give intramuscular, that can include a flu shot, can increase. Drugs that increase levels, salicylates like aspirins, hemolysis, and also don't forget alcohol intoxication. Okay, so that's it. Please know the levels, know the certain things that can increase, and that's it. Okay.